Assalamu alaikum. Welcome to California Care. Today we're going to talk about basic implant components, literally how things work. This seems to be a finished model. The key components are the implant, the connector to the tooth or the crown, which is called an abutment. Only part of the abutment shows here. The abutment is on the inside. And the critical factor is the way the crown comes in contact with the abutment and rest of the implant. This has to be very smooth margin here, and it has to have good emergence profile, no ledging, and definitely no open margins all around. Here's a little crevice as far as the margin is concerned, is slightly open. That's where the bacterial contamination will happen, and it must be sealed hermetically with resin-based cement, dual cure. So we're going to keep this model as a base and then explain the components. What I normally do is we have an access hole right here through the occlusion. So the implant retention screw, the screw that retains the abutment to the implant, can be undone and the whole assembly be taken off in case you need to clean the margins all around. So I'll put this here. This is basically what you have. I'll explain the component names and then explain how they're used. There are two kind of drivers, like screwdriver in a way. But since implant components have a hex type of shape with 6 sides, that's called hexagonal shape, the drivers are called hex drivers. So there's a first driver, which is hex driver, that fits into tiny screws, okay, like this one or this screw. These are two different screws. One is called cover screw, one is called retention screw, and then also there's a hex built into a healing abutment. But wherever you see a small hole, the small hex driver fits into it. Then what we have is another driver, which is called an implant driver. When the implant comes, either this driver fits into the implant to place it inside the socket or the osteotomy, or in better systems you have a driver that fits into the implant abutment, you see, and then you're driving the implant inwards, and if the abutment is on it, that way you will find out where the implant is placed and if it is placed at the right level. Majority of the time I see that the implant placement vertically is deficient because nobody accounted for this thickness of the abutment collar. The collar is the part which is smooth and no crown goes on it, and the example is right there, you see. So the crown is going to sit at the margins, and there is a collar of the abutment below the margin. And if you place this implant slightly higher, then of course the abutment collar is going to take up the space, and then the metal is going to show in the mouth when the implant crown is completed. Hence, the implant must be placed hopefully with the abutment on. That way you know where the facial margin will lie. The facial margin should be in line with the adjacent two teeth CEJ. That's where the CEJ is at the deepest level, apically. Hence, it's better to buy an implant system with the abutment already attached to the implant and a driver that holds the abutment and carries it into the osteotomy site. Some other implant systems do not have the abutment, but a fake abutment. That's called an implant carrier. It's a carrier which is like an abutment, and it fits like an abutment into the implant itself, but it's a fake abutment that you throw away and you can use a real abutment afterwards, called an implant carrier. I think that's also a good idea, because when you're placing an implant with the implant carrier, then in case there's anything that gets damaged while you're placing the implant, the damage is at the abutment level, which is the fake throwaway temporary implant carrier abutment. But anyhow, so this is the second kind of driver. So what that means, normally there are only two screwdrivers or two hex drivers. One is the hex driver that we use mostly, and the other one is just used at the time of implant placement. Now these drivers themselves can be screwed with fingers, or you can use a finger driver that goes on top of this, and then you can tighten it, or you can use a long handle like an elevator and tighten like that, or you can have a ratchet which goes sideways just like the car mechanic uses it, and that is also available. So anyhow, we're going to put this away and assume the implant is placed in. Now just to give you an idea, this is an actual implant and an abutment. So we're using a very, very large model to demonstrate what an implant component system looks like, but it's actually that thin. So imagine something has to go inside that, then the screwdriver or the hex driver is going to be even much thinner. And this implant carrier or implant driver is going to be definitely much thinner and smaller. So this is the real size here. So let's say you have placed the implant into the bone, and then you have taken away the abutment or the implant carrier, and you have placed it away after sterilization for using it when it comes time to restore the implant with the crown. So we'll put that away. Now once this is inside the bone, you'll be able to see the green or the yellow or the purple, whichever way the implants are coded, color coded. Normally yellow is the thinnest implant, then comes green, which is slightly wider or thicker implant. Then you get blue, which is even wider and much thicker implant that's used in molars. And then you also have 6 millimeter wide implants. They are normally purple coated. The implants also come with a cover screw. What that means is once you place the implant inside the bone, you want to cover it temporarily. If you leave this socket open, bone will get inside and contaminate the threads and grow into it. That implant is essentially lost because you cannot take away the bone that has grown into it. And if you try to use any mechanical means, you're going to then damage the threads inside. And then whatever component you put on top, especially this very fragile, very tiny little screw to retain the abutment to the implant, is going to be damaged and you won't get full seating. So it is extremely important to take a picture right after you have placed the implant. Then you cover it with a cover screw. The cover screw is very thin up on top, but it goes into the implant and you place it in, and it has little space left. And remember, there's a tiny little hole, so it's a tiny hex driver that goes in, and then we tighten it. When you tighten it, you want to tighten it a little bit, not too much. You don't want to torque it. If you torque it, then when it comes time to remove it, you won't be able to remove it easily, and that would put negative torque on the implant itself. So you tighten it, and you can practice it a couple of times that yes, it should seal fully, and you should be able to take it off nicely either. So tighten it very lightly, and then this is what it shows on the crest of the ridge or into the bone whenever you're done with the procedure, and you must take a picture of it. So you have record in case you're in doubt whether I close it or not. You can go look at the picture, and in case you don't have this picture, as soon as possible, open up the socket, even if it is healing up, and put a cover screw. But what happens is you get a little package, and in the package you have the implant components, all of them, and this cover screw is there. At the end, you make sure that everything has been utilized and used, and this goes in, and now you let the healing happen. For the mandible, it's highly recommended that you let the bone heal for 3 months. In maxilla, it's highly recommended that you let it heal for about 6 months so that there is osteointegration and the bones have matured. So let's say after 3 or 6 months, now you're going to make an incision into the ridge. There's a separate video I have that shows how to uncover the implant so you can create the papilla very nicely and not throw away the tissue that has grown so nicely, which is keratinized attached epithelium. Do not use mucotomes at the second stage surgery. You want to preserve the tissue and turn it into papilla, facial mesial distal, lingual mesial distal. So once we open it up, what we call a T incision, you open it up and you should be able to see this green deep inside the tissue. And now it's time to uncover it. So you're going to unscrew it like this, and cover screw goes off. Now what you want to do is you want to go ahead and take an impression of this. So this is what I would do. I would take the abutment and I'll place it in there. So now the abutment also has hexagonal sides. Implant itself has hexagonal sides on the inside. And when you put it in, it locks into one position. So you cannot derotate it. I normally like to place the facet on the facial side. But let's say by chance you ended up placing the implant slightly onto the distal, then you can put this facet on the distal so that the crown has more thickness available. Anyhow, let's assume we have placed the implant in the right position and this facet is on the facial side. Once the crown is made, and you'll be able to see the same facet on the inside. So when the crown goes on, it also does not rotate freely. Anyhow, now once it is there, there's nothing there to retain the abutment to the implant. So they have made something called A retention screw. It's a screw, not the cover screw. It has the same kind of threads, but a retention screw because it's going to retain the abutment to the implant. Now, when you see that there's a little platform on the inside and we throw the retention screw in, the screw part comes out the bottom. This is the part that's going to thread into the female threads on the inside of the implant. And this hex, which is male hex, is going to get engaged into the female hex part of the implant itself. So you'll place this in and we need to tighten it now. Now, as we're taking the impression, I want to very lightly tighten it. I want to make sure that this seats completely and there is no space right here between abutment and the crown. If this does not seat completely, let's say in this position, and the space is open and you take an impression like that, then the crown is going to be made, and once you even seat it, the crown will be in hypoocclusion. So we can't have that. It has to be seated all the way. And at this point, if you can visually see it with an explorer, that's great. Otherwise, at this time is a critical checkpoint where you take a radiograph to make sure that there's no space open right there. So you place this in, and in this place, I'll take some Teflon tape, the same Teflon tape that the plumber uses. The Teflon tape comes in two forms. One is white and one is yellow. We want to utilize a yellow one because it's thicker. White is thinner and too fragile. So you cut a little piece, and it should be about half an inch, like about a centimeter or so of the Teflon tape, yellow one, and you place it inside. Teflon tape is great. You know that your pots and pan in the kitchens are also covered with Teflon. So Teflon has a very, very high melting point, and you can take Teflon tape and you can sterilize it in either autoclave or dry heat sterilizer. It's not going to melt, so you can utilize totally sterile material. So you'll take the Teflon tape and you pop it inside and lightly pack it. Don't shove it in there because you want to take it out. Lightly pack it and flow your impression material all around and take the impression. I will go ahead eventually show you how to also take the impression right and send it to the lab. There'll be a separate video and we'll do it on a real patient. Anyhow, you're taking the impression, and in the impression you'll have the negative aspect of this whole abutment. Now what you want to do is do not send just the impression to the laboratory, because when they pour it, they might not be able to see the fine margins, and the crown is not going to have this good finish like we do here. So what we do is I will go ahead and take off the actual abutment. This is what I normally do, and I'll send that to the laboratory. Now I'll take this off and I'll put it away. And at this point, the socket is open. We're not going to put the cover screw back on because we're done with the cover screw. The healing has happened. So now in this healing phase of the soft tissue, the bone has healed, but now we've just cut open the soft tissue. So we want healing of the soft tissue. So we're going to use a fake abutment. See, this was a real abutment where the crown is going to go. Now this is a fake abutment. It's like a dummy crown, and it's one piece. And I'm going to use that and screw that in. And it screws in, and you can use a hex driver again. So you screw it in and it goes into the implant and it stays there during the healing period of the soft tissue. That's why it's called healing abutment. And as the tissue heals up, it heals up around this abutment. We can customize it. And there's a separate video that I'll show in which I use this slot. I take steel ligature from ortho and I tie it inside and I tighten it and twist it, and the wires come on the side. Then I flow flowable composite all around to make it have an appearance of a crown. Not full crown, but half. So it would have good emergence with this taper. And as this taper is built into the healing abutment, then over a week or so, the socket will develop and heal around a fake healing abutment and give you better aesthetic results in the papilla form. Anyhow, so here, after about 3 or 4 days or a week, the crown comes back in, and it has been made on actual abutment. The abutment, the way it goes to the lab, it gets attached to a fake implant that's called lab analog, and then it sticks out of the cast just like a natural tooth. They can see the margins exactly, and they can scan those in or wax them up. I recommend only zirconia. As they scan them in, they're scanning the real margins. So when they manufacture a crown, the crown fits dead on to your abutment. You see? So manufacturing errors are reduced like that. Anyhow, so a week later, the crown came back in from the lab, and on the cast, I have evaluated the margins. Everything seems just fine. Now in the mouth, I want to try it in. So I want to make sure the interproximal contacts are tight and the occlusion is also great, and it is in hypoocclusion of about 10 microns. So what I'll do is at that time, I'll go ahead and unscrew the healing abutment. The healing abutment comes off with the hex driver like we have used in the past, and off it comes. And then we will take the abutment that the crown came with, the real abutment, and place it in the same position. So if the facet was on the facial, it goes into the facial, and I'll go ahead and lightly tighten it, not too much at all, and make sure I check the margin. Again, this is a critical checkpoint because now we are adjusting the occlusion. And I'll go ahead and take the crown that came in and I'll put it on. Now, once it goes in, I check the margins again with an explorer, and then I check the interproximal contacts with a floss, piece of floss. The floss should be about a foot long, so you can wrap it around your fingers and check the margins and the contacts are supposed to be tight. Now at this point, I'll go ahead and have the patient bite down and check with the articulating paper if the occlusion is high. If the occlusion is too high, that means you can see the bite open. That means the implant never sat, abutment never sat all the way down. So check the margins again. And if the tissue has healed up, take a radiograph to see if the abutment has sat completely. And once this goes in, I would go ahead and use the articulating paper to make sure that there's no high spots. I'll adjust them. Then I'll use a piece of shim stock. Normally the articulating paper is about 80 to 100 microns thick. That's 1/10 of a millimeter. A millimeter has 1,000 microns. But shim stock, if you buy to check the bite, has a thickness of about 10 microns, 6 to 10 microns. So I would make sure that I put my shim stock, which is very, very thin, on top of the implant crown at that time and try to pull it. If there is a contact on the other teeth, then this will put very easily. But if only this tooth is touching, the implant crown is touching, and no side teeth are touching, I won't be able to pull the shim stock out. But if I put it on the adjacent tooth, the shim stock comes out. That means the bite is still too high. So we'll keep on adjusting till shim stock does not pull from the adjacent teeth. But when you place it on this tooth, you barely can pull it out. What that means that this implant is now about 6 microns in hypo, not hyper, hypoocclusion, which is wonderful. This, you do not want to overload the implant. Implant failure, number one cause is over retained cement right here. Number two cause is uneven occlusion. We want to make sure that the occlusion is even and it's not in hyperocclusion. So if I'm able to pull the shim stock, which itself is 6 microns thick, that means that I'm definitely not hyperocclusion. I'm in slight hypoocclusion, 6 microns out of 1,000 microns in a millimeter. What that is going to do is the opposing teeth will adjust the occlusion. They will micro erupt and fill that 6 micron gap, which is definitely not clinically testable, and the implant never gets overloaded. Natural teeth have PDL space that does depress whenever the patients chew, and they chew with the chewing force. The teeth do get depressed about 10 to 15 microns. So you want to leave the space so the occlusion is not traumatic on an implant. It's a very, very important aspect. At this point, the zirconia crown isn't good final dimension, but it has not been finally cooked yet. So after I've done all the adjustment at this point, I will send it to the lab. A lot of people do adjustments after cementation, but then the surface will be left rough, and that's not a new crown surface. So I have put in this extra appointment, and I do this at this stage. Now what I also do on the implant, normally new abutments that I'm buying have slots, kind of like these slots all around. So they provide also physical retention for the cement. Otherwise, what I would do is I would tell the laboratory to put dimples in there with a tiny little burr in this metal all over, plus sandblast it. Sandblast creates a very rough surface. So cement will have micro adhesions to the physical aspect of the abutment. Another thing I do is on the inside of the implant crown right here, I ask them to put little dimples on the inside also, so the cement will physically get locked into it. With all the technology advances in cements, we still have a problem with full adhesion of any cement to the inside of a zirconia crown. That's why we sandblast the inside of the zirconia crown with aluminum oxide particles. So it is important to get physical retention inside and put dimples on the inside. And the labs would do it at this stage. It's very easy to do. Then they go ahead and do the final cooking on the crown, and it becomes very shiny and nice. Another point to mention is once the implant crown or zirconia crown is fully cooked, it's very hard to trim it even with diamond. But at this try-in stage, when it's not finally cooked, it's easier to trim the zirconia and it feels like you're working on porcelain crown. Anyhow, so 2 or 3 days later, or 4 hours later, 6 hours later, the crown comes back. I'll take the actual abutment, and I've tried everything now on the implant itself, and I'll go ahead and place the abutment, tighten it. Now, this time you still don't tighten it fully. You tighten it lightly. Then I'll fill the space up with new piece of Teflon to make sure the cement does not get inside and occlude the head of the cover screw. If the head of cover screw is cemented, you cannot undo it later on. Even now, you can't undo it. Now, that's a loss. And if you take a drill into it in such tiny little space, you'll end up either destroying the abutment or the screw head. So don't ever do that. Make sure you use Teflon. Never use cotton inside either, because the cotton is a huge breeding ground for bacteria. It's filamentous, hence it sucks in all the moisture, and the bacteria grow in it very nicely. We do not want to use cotton. Use Teflon. So anyhow, you have lightly tightened and made sure the abutment sits all the way onto the implant, and then you're going to take the crown, which is going to have a hole through the occlusion. Make sure there's a hole through the occlusion, because although we are cementing the crown to the abutment, so it's a cemented restoration, but it's also screw retained, and I'll show you how. So we mix the cement. This is inside the mouth, and at that time you do not try in the zirconia crown, because we have already done the trying in. Zirconia has very, very strong affinity for phosphate ions. The saliva and the blood are full of phospholipids. So if this gets contaminated on the inside, even a little bit of addition that we normally get from cement is not going to work. So this has to be totally dry. You go ahead and have somebody fill the inside of the crown itself with cement. You keep this very nicely dry, and once it's dry, then you go ahead and take the cement inside the crown, and you seat it all the way down. When you seat it down, you'll see that cement is oozing out of here. So what I'll do is I put a cotton roll on the mouth and have the patient bite down real tight so this crown seats all the way. Then I'll take the cotton roll out and check this area with shim stock. Does it still pull? Yes, it's supposed to still pull. That means the crown has seated all the way down. Once it's seated all the way down, I'll put the light up on top of this crown and press the crown down with light and cure it. Do cure it 2 or 3 times, and then you'll be able to see that the Teflon is shining through and there's a little bit of cement. You can poke away the cement with a handpiece burr or with an explorer, and the burr tip will touch the Teflon and it won't hurt the retention screw deep inside. Now, once everything is cured, you cure from the buccal and you cure for the lingual. You don't have to worry about cleaning the cement all around, because at the end, what we're going to do is we're going to unscrew the whole assembly. We're going to take the Teflon out of here, put the hex driver inside, and when you unscrew it, this whole thing, and I'll just give you a demonstration here. The whole abutment with the retention screw comes out like this, and implant stays inside the bone. Now when you're holding it, you can take another fake implant, put it in and tighten this whole assembly, which is cemented, onto the fake implant, and then take a look at the margin. Pick up a nice composite polishing burr and clean it all around. Once it's cleaned, you'll take a look. In case there is any discrepancy anywhere, you can wash and dry it, apply a little bit of adhesive and a little bit of cement or flowable composite, smooth it over and cure it. But at this time, you cure each surface also independently, and this is in your hand. You cure everything, you smooth and polish this area right here. So this way is the only way you know that this is hermetically sealed and there's not even a slight sliver of excess cement left anywhere. I see examples. This is an example in which, if you take a look, the margins are sealed and there's tons of excess cement left all over. This is a primary cause of failure, and this implant was failing on this patient till we took this off. Not only did we do a proper crown, but we did bone grafting and the implant itself was saved. Emergence profile is important because you do not want these kind of plaque retentive designs where there is Food impaction. This is an actual implant case where the implant was lost because of the pontic design and the abutment design. Anyhow, once you have cleaned and polished all around with a composite polishing burr, you go ahead and now you pop it back into the implant and tighten the screw. Once you have tightened the screw, I would tighten it only to about 6 to 10 newtons. If you over tighten it and the screw breaks later on, you have a big problem. In my case, for about every 100 implants that I do, maybe one of the implant would have the screw coming loose over a year or two. Not a big deal. I'll go ahead and tighten it again. But if I see the patient routinely, which I do, every year or 2 years, I'll go ahead and actually remove this assembly, take a look to make sure there's nothing in there, and take a look at the health of the implant and screw it back in. Now, here is the point. When you're screwing it in this space, you can have moisture left inside, and that could breed bacteria. So you dry this nicely and take a little bit of either silicone or petroleum jelly, which is sold under the brand name of Vaseline, and put a little bit inside. Now, when you seat this and you tighten it, the Vaseline or the petroleum jelly or a little bit of silicone is not soluble, water soluble. Whatever was in the sulcus gets washed away. Whatever stays inside, it does not allow the bacterial seepage to happen. You'll go ahead and tighten this nicely tight onto the implant again. Tighten it to about 10 newtons. A lot of manufacturers recommend that their retention screws be tightened to 30 newtons. But then in case it breaks or you have to undo it, it's a big problem. So I would tighten it only to 10 Newton, and believe me, I have thousands of implants in service where the screws don't come undone at 10 Newtons. Then in the same space, to protect the cover screw, the retention screw, I'm going to put Teflon inside. Once the Teflon goes in on the top millimeter or so, I would go ahead and color match the composite and fill the space and cure it, and that's it. The implant has been delivered, and you can expect now years of service because you have not violated the biological principles by creating the crown, which is in proper propositions plus proportions, as well as emergence profile. And also mechanically you have tightened it nicely, and physically there's no space left at the margin for the bacteria to go in, and then you can say it should last, inshallah. I hope this makes sense to you. If you have any questions, feel free to contact me.